Thank you to everyone on the live stream, and we're really appreciative of you joining us this morning to discuss positive partnership for public health, the relationships between supervised acceptance services and the police. My name is Elaine Heshka, and I'm an assistant professor at the School of Public Health at the University of Alberta. And joining me today are three panelists. But before I get to introducing them, I just do want to acknowledge that we are situated, all of the panelists are in Edmonton, Alberta, and we're situated on Treaty 6 territory, which is traditional lands of First Nations and Métis people. So I'll introduce our panelists and I'll introduce our talk, and we'll take it from there. So our first panelist is Hannah Brooks, and she's a data coordinator for Edmonton Supervised Acceptance Sites and also a research assistant with the Inner City Health and Wellness Program at the Royal Alexandra Hospital in Edmonton. She graduated from the School of Public Health at the U of A, and her research interests include substance use and harm reduction. Hi, Hannah. Next is Erica Schoen. Erica Schoen is the director of one of the supervised acceptance services in Edmonton. As a registered nurse, mental health therapist, and harm reduction advocate, Erica has spent the last 10 years working in a variety of roles in community mental health, public health, crisis response, and public education. Working closely with law enforcement, the provincial government, and federal health authorities, Erica has advocated for evidence-based system reform and public safety initiatives. And our last panelist is Daniel Jones. And many of you may have seen him at other events, as I know he's been fairly prolific at this conference. Dan is an inspector with the Edmonton Police Services with 26 years experience in the justice system, 23 in policing and 3 in correctional services. Dan worked in patrol, foot patrol, homicide, professional standards, specialized investigations, and Indigenous relations. He earned his master's degree in applied criminology and police management from the University of Cambridge and is currently a PhD candidate at the University of Huddersfield. Daniel's research centers around incarcerated men and women in the victim-offender overlap. And Daniel is a collaborator on the University of Alberta Prison Project that has interviewed over 800 participants. So welcome to our three panelists. And I'm really looking forward to their presentation today. I'll be moderating the discussion after, but essentially we put this panel together in part based on a request from Nick Crofts, who I recently submitted a journal article to at a journal he was editing, and had suggested that he'd heard a lot of good things about how the police and the supervised acceptance sites interact and partner in Edmonton, and suggested we consider putting in a panel. So here we are. So with that, I'll turn it over to Hannah to get us started.
Hello, everyone. As many of you are aware, drug policy can vary significantly across the world. However, growing evidence demonstrates that the war on drugs has failed. In response to this failure, the Government of Canada developed a 4-pillar approach to drug policy. One pillar is prevention, another is treatment, and the third is harm reduction, which aims to support measures that reduce the negative consequences of drug use. Harm reduction recognizes that there is a spectrum of drug use, from beneficial to problematic, and that not all people who use drugs need or want to access treatment, and that drug use should not be a reason to exclude people from accessing healthcare and social support. The final pillar of Canada's drug policy is enforcement, whose primary aim is to address illicit drug production, supply, and distribution. All pillars are supported by a strong evidence base. Evidence from empirical research indicates that people who consume drugs are at increased risk of experiencing social and physical harms. They are also more likely to experience frequent and costly medical treatments and experience sanctions by law enforcement. These harms I just described increase significantly when use occurs in public spaces. These people often consume drugs in unsterile settings, such as alleys, and consume alone. These circumstances leave people at increased risk of infections, overdose, and death. People may also fear public surveillance and arrest by law enforcement, and as a result, rush to inject so they aren't caught. But this causes injection-related injuries. Or they may refuse to carry or access sterile drug consumption supplies, and as a result, share or reuse supplies. Supervised consumption services, or SCS in short, were developed as one way to reduce these harms. As Elaine said, we're all from Edmonton, Alberta, Canada, which is a large city that experiences significant inner city poverty and drug use. In order to reduce the harms associated with this drug use, beginning in 2012, a coalition of 25 organizations, including the Edmonton Police Service, came together to explore the need for SCS in Edmonton's inner city. In 2018, 4 SCS opened. One opened at Boyle Street Community Services, which is a community center. Another opened at George Spady Society, an overnight shelter and medical detox. A third at Boyle Macaulay Health Center, a primary healthcare clinic, and a fourth at the Royal Alexandra Hospital, which is for registered patients only. In 2020, the Boyle Street SCS was relocated to a 24/7 shelter at the Edmonton Convention Center to better service community members during the COVID-19 pandemic.
Okay, so just to speak a bit about how SCS generally works, after a low barrier intake and assessment, people are welcome into the site in order to consume pre-obtained drugs. We offer sterile drug consumption supplies, a clean supervised environment where people can legally use drugs, emergency care in the event of an overdose, health education with a focus on the prevention of negative consequences actually associated with a variety of health topics, not just drug use. We also often offer naloxone distribution and training. These sites are often paired with medical staff. Sites do have varying staffing complements. There's nursing and healthcare services often. Some sites offer drug checking, allow for peer-assisted injections. Many and most offer holistic care planning and case management around referrals and client advocacy. It is extremely difficult to connect people without a ton of advocacy due to stigma within our systems. So that's of people who use substances, people with mental health issues, and those without homes. Just some of the objectives of the service. The overall objectives: to reduce high-risk injection behavior associated with HIV and hepatitis transmission and other drug-related infections, reduce the incidence of overdose and overdose-related deaths, reduce public injecting and associated needle debris, facilitate links between people who use drugs and health and social services, such as testing and treatment, housing, employment support, opioid substitution therapy, and other forms of treatment. A big focus of these services as well is to improve quality of life and to help reinstill hope for a highly marginalized group of people through ongoing education and unwavering support. Just going to talk a bit about the general layout of a site. So in this example, this is a mobile site, but they're not restricted to this model. So we do have the intake area that I mentioned to the right, where pre-use assessment is completed. We find out what drugs people are using, any recent overdoses that they may have had, any breaks in use, which will affect their tolerance and risk for overdose, and any additional health risks that we should be aware of. People wash their hands, they grab supplies, and then they use in one of the booths, or this could also be simply a table. Clients are monitored by staff who can immediately respond if necessary. And then once safe, medically safe to do so, people exit the service with referrals, resources, including a naloxone kit. Really important to note, every needle that's used within these sites goes directly into a biohazardous container, and there's no needle sharing within any of these services. There are multiple models of supervised consumption, including fixed independent sites. You may know of Insight in Vancouver, sites embedded within existing organizations such as ours here in Edmonton. Lower barrier, the mobile site, sorry, which is the example that I showed here, and then low barrier, less medicalized, and sometimes temporary sites known as overdose prevention sites, or OPS. These overdose prevention sites are often seen in housing, sometimes virtual programs over the phone for people that are often at home using alone. And actually here in Drumheller, we also have a site in one of our correctional facilities. So the main goal of an OPS is to have someone around for a timely response to an overdose. In terms of drug consumption routes, in Canada, many sites have focused on injection, but also allow for intranasal or snorting, oral use. Some offer inhalation. In terms of a true harm reduction program, these services would include all forms of consumption. Unfortunately, we are seeing an increase in overdoses and overdose-related deaths around inhalation. So this is really important that some changes are made around this. And to operate these sites, an SCS must hold an exemption from the federal government under the Controlled Drugs and Substance Act, Section 56.1. This allows for legal drug possession within the service and drug consumption within the consumption space. And as this exemption only applies within this space for a truly successful service, the relationship with police is imperative.
Just as Erica said, SCS do not exist in isolation. It is important to consider their relations to federal and local law enforcement, as law enforcement officers are key stakeholders in the process of establishing and running an SCS. Law enforcement officers around the world are increasingly expressing frustration at the so-called revolving door phenomenon, in which people are arrested, detained, and released, only to be arrested again. Instead, many jurisdictions have begun to incorporate the policy of harm reduction policing, which involves police participating in practices that aim to build trust, taking actions to address the needs of individuals who use drugs, and making changes to their methods of drug law enforcement. Harm reduction policing involves a philosophical shift, which recognizes that people unable or unwilling to abstain from illegal drug use can still make positive choices to protect their health and well-being and the health and well-being of others, and that police can help facilitate these outcomes while advancing public safety. So how can harm reduction policing be implemented with regards to SCS? According to the literature, a significant amount of mistrust exists between SCS staff and SCS service users and police officers. There's documented evidence that suggests that law enforcement practices can contribute to either the success or failure of SCS by police officers acting as enablers or deterrents to accessing services. For example, routine policing in the enforcement of warrant searches in the area surrounding SCS and other acts of police engagement often scare service users away. In addition, some staff have described responding to overdoses alone rather than calling emergency services because they were afraid the police would also respond. However, there are positive examples of police engagement. A study in Vancouver found that among 1,090 individuals who had attended an SCS, 17 have been referred by local police. SCS around the world who have successfully sustained relationships with police indicate the following are key: early engagement between staff and police officers, regular equitable communication, supportive police leadership, dedicated liaisons between police and SCS, and a negotiated boundary agreement where police officers will not interfere with those attempting to attend the SCS, and crisis management agreements that guide SCS staff and police officers on how to respond to particular situations involving the SCS. And now Erica would like to talk a little bit about her experiences with the Edmonton Police Service.
As Elaine mentioned, I have worked in the inner city of Edmonton for over a decade. I have had various experiences throughout as working as a nurse in the inner city prior to managing the site. But I do remember one time being pulled over by an officer when I was taking a client from a health clinic to the community center and basically interrogated with how I knew this person. And when I explained I was a nurse, I was told, "Oh, I guess you don't look like a drug user." I don't know what a drug user looks like, but anyway, with this service specifically, I've had more than one officer ask, so they just use drugs and you just let them back out into the community? I've seen a ton of stigma around people using crystal methamphetamine, that anyone using is dangerous and psychotic. This actually continues within our society overall. 40% of people who use our service actually use crystal meth, and this has not been our experience. I've also witnessed a lot of misinformation and miseducation regarding secondary exposure to fentanyl. There is a link attached from Health Canada if you're interested in some of the myths and facts around that. There's been an assumption that the service would increase social disorder. So I know the police did surveillance, our community center for a year. Dan may touch on this, but that was not reflected in the evidence. There has also been a lack of support and collaboration with the SCS staff. So one of my favorite parts of my job is actually doing tours of the site. I often witness epiphanies where people finally understand the goals of the service. So I actually offer tours to anyone and everyone. I did offer a tour to an officer on one of our mental health teams here in Edmonton, and I was after they told me they just don't think the service is a good idea, sorry. Yeah, when asked if they wanted to come for a tour, maybe learn about the program, they just said no, they're not interested. So staff have voiced they felt they were part of the scenery at times. They felt ignored and their input discounted. I do also remember a staff one time, staff were dealing with a medical emergency in the hallway of our community center. And there was an officer standing with his arms crossed, watching and laughing as he was telling his partner here that they don't know what they're doing. So we had one particular incident that happened at the very start of our service at Boyle Street. We had a client experiencing what we now know as an atypical overdose. Staff called for emergency services because of this. So with an atypical overdose, we're seeing kind of abnormal movement, uncontrolled body movement. This client was grunting, kind of moving all over the room. He was able to comprehend and somewhat able to verbally respond. There's a link as well around that. And then prior to calling for medical support, like overall the room was calm and manageable. There were other clients in the booths, and this one client was in distress. So staff were basically just trying to ensure his safety, moving chairs out of the way, trying to direct him into a more open space, and then just kind of guarding him from any sharp corners that were in the room. Within a few minutes, we actually had multiple police show up, and then EMS. So we had a room full of clients and staff and EMS and police. I don't know if you saw the other slide there, the one with me in it, but the room is it's pretty small. And then additional police came on scene, and staff actually tried to stop them from coming in, just saying, again, the client's not violent. There's way too many people in this room, and the heavy police presence is actually just causing more chaos and fear in this situation. Despite this, the police pushed their way through the staff, completely disregarding them. They tried to forcefully handcuff the client as he continued to experience the dyskinesia. So he's like flailing, screaming in pain and calling for help. This specific client had multiple injuries to both hands and to most of his fingers due to a really severe frostbite infection. So like his hands were so delicate, basically standing in the wind caused him a lot of pain. So so staff were just trying to stop this. So from this point, he was handcuffed, he was pinned to the ground, and the handcuffs were rubbing his raw hands, just causing further pain to him. Instead of stopping, the police shouted that they were running his name for warrants as 4 officers piled on top of him to stop his body movements, which people were unable to do. So there is obvious panic in the room. There was clients in the booths. They were worried about being arrested. So staff were trying to protect them from the police, move them out of the room. It was almost like a fire drill, following them to provide support and reassurance in the other rooms. One of the officers tried to intimidate one of my staff into handing over the client's bags. And my staff actually refused, saying that people are actually legally allowed to possess substances in this service as per our exemption. So from this single incident, staff voiced feelings of guilt, defeat, and helplessness. They felt completely disregarded and that their voice didn't matter. Some even cried on the way home that day. They felt it was such a traumatic experience, and especially for someone so vulnerable. Needless to say, the word spread and trust was broken. I'd say even further between the police and the SES community, with staff and police, and to a degree with staff and emergency medical services. So with the potential to increase safety risks to both staff and clients, and the potential to increase negative health outcomes for the clients. We were kind of wondering, who can we trust to support us? Trust also broke between the SES staff and the community. So again, keeping in mind, this was a new service. Prior to this, people would grab supplies from the needle exchange and be told to go outside to use. So just getting used to the service existing was still a work in progress. So there was a police investigation. We spent a ton of time apologizing and reassuring the community, going out in the community and the alleys and trying to encourage people to come back, explaining like this shouldn't have happened and the police are investigating this and we're so sorry and please come back and give us another chance. So conversations took place between police, EMS, and the SES, just regarding how the initial call to 911 took place. And basically, we were told that because we used the word flailing, which I used in this presentation, but that dispatch took that to mean that fists were flying, that the client was violent, and then which is why police were dispatched on the call. Which still does not dismiss the behaviors that were seen by the police that day. And after this, Inspector Dan Jones here actually had the idea to do a video of the service, of the services, to help educate and demystify the space a bit. And this was shared citywide with the police. Just one quote from my staff about that incident. We already work with a population who does not have a great relationship with police. And to have these experiences just makes all of our jobs harder, both SES staff and police, way more difficult. We need to work together. So where we are now, in this next slide here, you'll see actually one of our police liaisons, Becky, giving the thumbs up in our overdose prevention site at the convention center. So this continues to be a work in progress, but I'm happy to say we've seen some positive changes with police related to the service in the 3 years since opening. I'd say due to de-escalation skills of the staff and just the safe and supportive environment of the SES. We've actually had to involve police fairly minimally. Most calls for service have actually been just to events that were around the building as a whole. However, when police do arrive at the center or they are called to the site, a conversation occurs with the police outside of the service, often down the hall, even away from our door. And prior to police entry, the staff are communicated with and advised by the staff if they are going to enter or not. This has given us a chance to actually give a heads up to people using the service and an opportunity to leave if they're uninvolved. So maintaining control of the environment and also maintaining that level of trust. We around joint advocacy for mental health, for support during a mental health crisis. My team, we actually have had more success calling the police directly than dealing with the mental health system. We do continue to ask the police for support around advocacy if someone is taken to the hospital. Oftentimes people who use drugs are discharged back onto the street without being assessed, regardless of the severity of their physical or mental health issues. This is often seen as their baseline. If you use drugs, then whatever's going on with you, that's your baseline. And the majority of the police that we work with know that this is not true. We've seen a lot of success with Edmonton Police Warrant Diversion Program. So with this, with permission from the individual, we share their name and birthday to see if they have warrants. They can voluntarily connect with a police officer, oftentimes with officers that we know and trust. They can have staff present for support during the conversation, and this gives the client more control. They can also ensure they don't have substances or paraphernalia on them, excuse me. And oftentimes they're given a break by police. Around public education and tours, excuse me, we've hosted a number of tours for EPS to learn more about the service, and we've had more interest in learning about the program and also just in collaboration overall. I do remember one particular joint presentation that I did with one of the police sergeants. It was at a correctional facility, and it was to security and to the healthcare staff there. And I often speak about harm reduction, but to have a police sergeant stressing the benefits of decriminalization, of course, is going to hold a lot more weight. And I think this unlikely partnership also sends a really powerful message about the importance of the service, which I really appreciate. Established modes of communication. Since the start of the site, quarterly meetings have occurred through a community liaison group with SES partnering agencies, community stakeholders, and police. And this is to discuss and address issues in the community related to the sites. We've had a few different police liaisons throughout our 3 years, and we have been consistently impressed by the supporting and caring attitudes of the people in these roles. Many have actually offered to offer if the clients have any questions, if they want to find out anything about any legal matters. We haven't had any takers, but it has been offered. So I think that's a good step in kind of building that relationship between police and the community as well. And when we have ongoing conversations with our police liaisons as well on how we can support each other for the benefit of the community. So sometimes even weekly, probably at least every 2 weeks, if sometimes just informally, but we do have an ongoing relationship. And actually just not too long ago, because of these atypical overdoses that I was mentioning, we're having very severe overdoses. With the permission of our community, our SES staff provided some drug samples to the police for analysis. And so just to help increase awareness and public health education. And then that was shared with various agencies and around the convention center. And actually just last week, we were invited, the supervised consumption and the needle exchange, some staff took part in a feedback session as part of the Edmonton Police commitment to action. So they wanted to know how they could work in a more supportive harm reduction manner. So fair to say, in order to move forward, what we need is a strong commitment from both sides to increase the health and safety of our community. Thank you.
Thanks, everybody. Yeah, that was what Erica said was great, just talking about the bumps in the road when we first started. And a lot of it's in relation to the vilification of drug use and the vilification of people who use drugs that has been going on for years. We don't have wars on things where the person against us isn't the enemy. And for years, we've had what's been considered the war on drugs. And oftentimes it's a war on people who've experienced a lot of trauma. And so from a police service perspective, it was about educating our members. It was about having a different understanding of who the justice client is. And fortunately for me, I'm a police officer, but I'm also a researcher who spends a lot of time with individuals who are incarcerated and talking about these things from a perspective that is different from with the incarcerated populations. But let's just specifically focus on the way it worked in Edmonton. All of our supervised consumption services went into existing places. We actually had relationships with those places. Yep, there were some bumps in the road. Yep, there was some concerns about supervised consumption services because there was just a real lack of understanding of what these were from a policing perspective. There was a belief that this was going to increase harm to the community. There was a belief that there was going to be, detritus and a reduction in safety. And in fact, there were orders from the then police leadership at the time to take pictures surreptitiously of this SES a year before they started and then continue on to see. So there was a possibility of proving that this was creating harm to the neighborhoods. Interestingly enough, the pictures were actually reversed. It showed the opposite. It showed actually there was less garbage, less public usage, less of everything. And it actually showed in those neighborhoods where the supervised consumption services were, we actually started to see brightening of the neighborhood and less garbage and less issues. From a crime perspective, again, there was a belief that this would likely increase crime severity and calls for service. We saw a reduction at every single site of the three. We didn't do the Royal Alexandra Hospital because that's a very different style. That's an inpatient site. So we actually saw, I think the biggest reduction of crime was around 34%, and I think the smallest reduction was about 10%. But the crime did not increase at all at the sites. Now, the following year, we didn't do the analysis because things did change with COVID-19, obviously. So one of the sites moved, and so we haven't redone that analysis, but we will again, just to ensure that we're maintaining those understanding of it. But the education piece became really, really important. When we did the video, when Erica did the video and we put it out to the entire membership, people were very, very shocked that it was so medical. Everyone thought, I think everyone had it in their mind that this was like a trap house, and everyone was just laying around, and they had this kind of weird like opioid den from, you know, the olden days, and it's definitely not that. And I've even actually spoken to participants or clients that have said sometimes SES takes the party out of drug use, which is a kind of a funny comment, right? But having those conversations, having those candid conversations is hugely important, and bringing that understanding and advocacy. One of the other things that Supervised Consumption Service did was connect us to a group called AWARE, Alberta Addicts Who Educate Responsibly, I think I got that right. Am I right, Elaine? Did I get the acronym right?
It's technically Alberta Addicts Who Educate and Advocate Responsibly.
Thank you.
Very, very close. Yeah.
But it started bringing the concept of do nothing to us without us, which is a really harm reduction mindset. And it's from a policing perspective, it's the same thing. And we started to look at, you know, fortunately bringing in the research that I've done from my schooling and with the University of Alberta Prison Project, and started looking at what is the trauma implications of people who are incarcerated, and what is the drug use for. And yeah, there are people that choose to use drugs for all kinds of reasons, but there's also people that are using drugs to self-medicate to try to address traumas that have been in their lives. One of the examples I use often is one of our people in our sample, a 34-year-old woman with no previous criminal history, significant sexual violence from childhood on, was trying to get cognitive behavior therapy to address her trauma. And this is one of the things that I think we're missing, and I'll talk about that in a second, is different treatments. One single linear style of treatment for addiction is not going to help people. But what this individual was doing was trying to get cognitive behavior therapy, and waited for 3 years on a list outside of incarceration. What she found out was that the Edmonton Institution for Women actually had really good access to cognitive behavior therapy. So she walked into a bank with a toy gun that looked real, robbed the bank, waited for the police, got arrested, went to first appearance, pled guilty, got 5 years, and is now currently getting cognitive behavior therapy in a federal prison. Now, that's not me saying we need to build more prisons. That's me saying we need to do better for the population that's outside in our community, and that people shouldn't need to feel safe, secure behind a prison wall. One of the other things we do get a lot with specifically our women in the sample is drug usage for safety. I can't go to sleep when I'm on the street, because if I do, something bad will happen to me. So I use methamphetamines. And then when inside they say, oh, I'm so glad I just don't have to use in here. So it gives a different perspective, and we have shared this with our membership. We've started bringing in lived experience people to the organization, talking about their histories, because we see people in that one chapter of their lives and we label them as a drug user or an addict. We don't realize that these are individuals who are human beings, who've had human experiences, who have had trauma and are actually looking for help. And sometimes that help isn't available, and unfortunately they get stuck in a cycle. And when the help is available, it's oftentimes the linear help of a abstinence-based program for addictions treatment, which isn't always the right thing to do for people. And I think that's what we have to realize, is that if you've met one person who uses drugs, you've met one person who uses drugs, and everybody's journey is different. And we have to get our members to understand that, because we do, and we have over-criminalized a population of people who shouldn't have probably ever been in the system. And we start to look at symptomatic criminality, symptomatic drug use, and it's a symptom of something else that's far greater than what we're dealing with. And I think the systems as a whole have to start to address as a systems of a whole has to start being trauma informed and moving towards a model and a mode that we can work with people where they're at, not tell people where they need to be. And that's a big challenge for policing. So what we've seen is, as we've done a lot of education in partnership with Erica, in partnership with our other supervised consumption services, we've seen a shift in our memberships mindset towards this topic. We have a chief of police now in Chief Dale McPhee, who's very alive to the whole idea of public health and policing being together as one, and also talks about off-ramping, and rather than we can't arrest our way out of these problems, and let's look at alternatives and diversion and different ways to do things. Interestingly enough, what we've seen, and it's a different year with COVID, we've seen a reduction in a lot of crime in our city. Actually, we've gone down on some crime severity things. Certain crimes have gone up: domestic or intimate partner violence and child abuse are on a very unfortunate upswing. But other cities are experiencing different crimes going up, while we're experiencing different crimes going down. We can't say that that's because of one thing, but we can say that that's, I think, because there's multiple variables of change in our organization. One of the other things that the Edmonton Police Service has recently done, which will work closely in partnership with individuals who will be using services such as SES, is they help navigators. We have police officers now working in partnership with Boyle Street. Navigators, social workers that are working in a car together, bringing services to individuals where they're at and in the space they're at, to try to assist people to be healthier and a more well community. One of the things that we have to still work on, and we really need to work on, is the reduction of the stigma reduction, and also the conflation of homelessness, mental health, and substance use. Not everybody who's homeless has substance use disorder. Not everybody who's homeless has a mental health issue. Not everybody who has mental health diagnoses is a substance user, and not every person who's homeless is engaged in criminality. And we unfortunately conflate these things in the public eye and the community and the media, and it becomes just stigmatic issues for individuals living precariously housed or homeless, and also individuals who are using drugs. And just on a last personal note, I believe in supervised consumption, but I believe we need more than just supervised consumption. I have had a friend of mine died on Christmas Day of an overdose. And I've had another friend of mine, I've had more than one friend pass away from opioid use. So it touches a lot of people. It's touched me personally, and I think we need to do better. We need to do better for a population that is dying at a high level. I think the number was 1,254 in Alberta, is the number I think I heard for overdoses deaths last year. That's too many, obviously way too many. So supervised consumption services, I know without SCS, that number would be higher, but we're missing a certain population, and that population is people using alone at home. And we just need to work better at addressing those things from a holistic public health law enforcement perspective. Thank you.
Great, thanks so much, Dan and Erica and Hannah, for a very comprehensive overview of your journey together around SES and policing. So we're going to move to questions, and I see there's already a couple in the chat box, so I'll ask those first and then invite anyone else who wants to ask a question to either put in the chat or raise their hand. So the first question, Dan, is, and you did touch on this briefly, but could you speak a little bit in a little more detail around the public safety outcomes of the analysis you did, like around the 3 community-based sites?
Yeah, absolutely. So we looked at 2 different things. We looked at calls for service and disorder, and then we looked at crime severity. Crime severity, so the Canadian Crime Severity Index is an index that is set up by the federal government to look at the harm that certain crimes do, and it ranges from a number of 7,000 roughly for a homicide down to the old 0.34 for possession of marijuana. So you have this range. So what we did is we took the Crime Severity Index and we looked at the crime in and around about a 700-meter radius, I believe it was, of the supervised consumption services. And the reason we did 700 meters is because 2 of the services are so close together that 700 meters actually almost bumps into each other between Boyle Street Co-op and George Spady. So we looked at that, and what we did see was a reduction in both calls for service, disorder, and harm severity. So, and at all sites. So, and part of it, we believe was individuals who are now getting an opportunity to use in a safer space. And Erica made a point earlier is, do you just let these people use drugs and then send them out into the community? Oftentimes individuals who use the services actually stay for a while in the ante room, if you will. I know there's probably a better name for it than that. And get those services provided to them and are allowed to sit and not be at risk. And I think that's one of the things that we forget is I think as we conflate drug use with criminality again, and we think that someone who uses drugs is obviously going to go out and commit crime, when sometimes that individual uses drugs and when they're not in a safe space, they are the victim of a crime. And those things start to be reduced because they were now in a safe space with safe people. So yeah, we have not seen any increase in crime or disorder in any of our supervised consumption services.
And I believe around one of them, the crime went down, right? Like
it went down in
yeah.
all of them. It was down
Okay.
34% in around, I think 34% was, if I'm not mistaken, Well Macaulay Health. And I think it was down 10% on Boyle Street. And I think, and again, and we met with Saskatchewan when Saskatoon was setting up theirs, and they went to several different supervised consumption services and saw they kind of went all around the country and saw a lot of divisiveness between police and harm reduction people and staff. And they said, this is something totally different. We've seen in Edmonton, because not only did we take them to the supervised consumption services, we actually went to Ambrose Place, which is a managed alcohol living establishment, and very cultural. And they were just like, this is crazy that the police are this engaged in this, connected to the services. And like Erica said, it wasn't overnight. It didn't happen immediately. But I think one of the benefits of going into existing services is there was relationships in those existing services. Like for myself, I've been connected to Boyle Street Co-op for 24 years. I would walk beats in the initial stages of street works, and I worked in an area that was known for sex trade work. And Streetworks were partners and helped us maintain safety of the individuals working in the sex trade. And we had these relationships, and yeah, sometimes the relationships have to be rekindled because of events that, like Erica said. But it was really great to have them in existing services, and I think that's one of the things that I think a big learning that comes out of Edmonton.
Thanks, Dan. Oh, Erica, did you want to add to that?
Yeah, I just wanted to add, I know just in terms of pushback for the services in our city here, it was kind of, we were expected with a handful of booths at a few sites to solve the opioid crisis, which is obviously completely unrealistic. If I had my way, this would be like a Medi Center on every corner where people, if they wanted to use, they would have somewhere where they were welcome. There would be the stigma attached with drug use. They could go in. I think that would really help in terms of needle debris and public injections, and just decreasing the stigma and normalizing drug use. So also a really great way to connect people with services. So just anywhere within the city, if someone could just, oh, I'm going to use, there's a site. Right, and somewhere where people would feel comfortable with that. I do want to mention too, obviously, like Dan was saying, these sites aren't a panacea to solve the opioid crisis. I have seen people use our site and who have reduced their use simply by being housed. So housing is harm reduction to us. So just providing people that stability and security that Dan was also speaking to, that has helped people decrease their use. If they have hope, if they have a sense of purpose, if they're able to focus on something other than drug use, all of these things, and providing that support around that, that's how we move people forward. I don't agree that everybody has to go to detox and treatment. Oftentimes, I know people who've gone to treatment 30 times and they're still using. So, and I don't think that is something that is on the individual. I think that's something that we need to take a look at as healthcare services. Thank you.
Thanks, Erica. There's a question in the chat. I'll just read it. I think it's for you. So a legally operating post-consumption site in the US found that their service inadvertently addressed a previously unidentified need for women namely providing a safe space to stay after use to avoid harassment and violence on the streets. And I think Dan kind of alluded to this too in his comments. The response was so overwhelming from women in the community that they started doing things like offering reproductive health care and even providing birth control out of a space originally meant for monitoring only. Has Edmonton seen any unexpected or unanticipated learning of this kind, or like successes like this? Have you learned about any community needs that were previously undefined or poorly understood in the process of offering supervised consumption sites?
Okay, you want me to speak to that? Yeah, so we do at the Needle Exchange at Streetworks out of Boyle Street. They have been focusing on a lot of things around women's health, around testing. The majority of programs actually in the inner city are outreach based. So we do focus on all of these things. Let's see what else is in here. Working on the front line as a registered nurse, I did used to work for Streetworks. Actually, I often saw so many barriers in connecting people, even with basic things such as like treatment and testing, where you have to give someone a requisition and hope they don't lose this piece of paper and that they make it to the lab and that there's an appointment for them. And a lot of people, as we know, don't have homes. They obviously don't have watches and calendars, and it's really hard to line all of these things up unless somebody takes someone there. So a big focus that we've had was bringing services into the sites. We did actually at our site a collaboration with the Northern Alberta program and Shoppers Drug Mart pharmacists, where we did lab work and actually tested and treated people for hepatitis C within our program. We were seeing people every day anyway. We had access to, this was oversight by the physician of the Northern Alberta program, and we had people actually clear the virus while they were coming to the site. So I know Vancouver has done a lot around women-specific sites. We haven't yet. We're trying to expand as we can in our province. We do have a lot of pushback, I would say, in our province specifically. Yeah, we do have a focus on this, and really whatever makes sense within these programs. If someone needs a pregnancy test, then yeah, I don't see why we won't do that. We've done flu shots. So just bringing the services to the people instead of expecting people to navigate this silo approach to healthcare, which is the biggest barrier that we see aside from stigma.
Thanks, Erica. And I think too, it's important to like reinforce that it was a long process in getting the supervised consumption services open in Edmonton. Like we started in 2012, meeting regularly a coalition of 25 different community agencies that included Boyle Street, included Boyle Macaulay, George Beatty, as well as the police at the time were there. They attended, but their messaging around it was, we're here for information. We're not supporting or opposing, which was fine. We welcomed them to the table, and we were happy to have them there and have their perspective. And it took a lot of advocacy municipally, which, really the municipal government doesn't have a ton of authority over these sites, but it's kind of important to have their support, I think, for things to go smoothly. And then also with the provincial government for funding and the federal government to get the exemption. Since that time, like the service is all open in 2018, as Hannah mentioned, we've had a change in provincial government. And so the context has changed, and this government is much more adversarial to all harm reduction, not just supervised consumption services. So the sites are kind of now navigating this new reality where, despite showing positive outcomes, they're still at risk. And so I think that's what Erica was trying to explain in that, why they have not been able to expand probably to the degree that they would like, or to offer new kinds of services and programs. We do have another question in the Q&A, and this sounds like could be for Dan, Erica, or Hannah. How do you address criticism from other police forces that the police should not get involved with supervised consumption rooms, that this is work that should be left for health and paramedic services only?
I will take a stab at that one, if that's okay. So I think there's a learning here that we should look at. Is there's two pandemics currently going on, or two public health crises. One is COVID-19, and I think we've learned about that, and one is the opioid crisis. The police are expected to do all kinds of things around the pandemic, and this is where I think the blend needs to happen more with public health. Policing, it should not just be an enforcement-based service. It should be, it's a public health service. And if you look at the social determinants of crime and the social determinants of health, they are absolutely linked together. There, I actually have an article coming out in the Police Journal that literally points this out. It's been accepted for publication. So if anyone wants it, get a hold of me and I'll get it to you. Because we can't do this without the public health workers, and the public health workers, in my opinion, can't do it without our support. Because if all of a sudden we go, yeah, we're not going to get involved in that, we're not going to be harm reduction, I'm going to wait outside of the supervised consumption and use it as a fish pond and arrest everyone going there, and all of a sudden I can arrest a whole bunch of people for drugs, knowing that they're likely carrying drugs to walk into supervised consumption services. So those partnerships need to be happening, and they need to be human-centered. We need to really start focusing on what is our role, and what is our role, or what our role is community safety and well-being for all. So stop the stigma, stop judgment, stop vilification of drugs and people who use drugs, and start working towards health outcomes for a safer city. That's kind of what I would say to anyone questioning the police involvement.
Thanks, Dan. I think that's a really strong way to end it. So unfortunately, we do have to wrap up as there's another session starting in 10 minutes. But I just want to thank everybody for attending, for asking really insightful questions. And of course, if there are any other questions or you want to talk to any of us in follow-up, we have all figured out the Swahova app and are available to be messaged through there, or message one of us and I'll share, like if you message me, I can certainly share contact information of the other presenters. So thank you very much. And thank you to our amazing panelists today.
Thank you, everyone.